Hi everyone. Can you hear me okay?
Yeah, we can.
So hi, thanks very much for inviting us to talk today. I'm Selina Stellman, I'm a GP working in North West London and in Surrey, and my colleague Carl Sahota works in the personalised care team, and she's going to be, we're going to be sort of co-presenting this today. And this is really a project that we've been doing in North West London over the last sort of 2-3 years, which is around introducing a personalised care approach to supporting people with chronic and persistent pain. Slightly different angle from some of the other presentations, and this project was really around actually trying to reframe some of these people who are being at the moment referred into secondary care, seeing whether we can support them in primary care, but while still maintaining a link between primary care and secondary care, and using really all the members of the healthcare team across the board to support these people when and where they need it in a personalised care approach. So if we go on to just the first slide. So people with chronic pain. So these patients are often very complex. They've got complex medical, physical, psychosocial needs, and this is often on the background of people who've had significant emotional or childhood trauma, making them really quite challenging for them to navigate the healthcare system with all of their complex needs. They're frequently high users of primary, secondary and out of hours and unscheduled emergency services. But in spite of this, they still report having very poor experiences of care. So they're often under multiple different specialists. In primary care, they get these really short GP appointments and a lack of continuity, which doesn't help with them being under lots of specialists. There's often a lack of GP knowledge and confidence in managing chronic pain. And all of this really results to them being often inappropriately managed in the system. So they're over-investigated, they're given unnecessary analgesia prescriptions, which don't work and give side effects. And they're often inappropriately and unnecessarily referred into secondary care, which is just not a helpful use of anyone's time and not also necessarily beneficial for these patients themselves. Next slide, please. So with this in mind, we designed a kind of pilot model. The real aims of it, of this project, were to sustainably improve health and well-being of people with chronic pain. And that was by proactively trying to help them to increase their knowledge, their skills and their confidence in self-management. We wanted to try and tackle some inequalities through supporting engagement with local communities, because we know that people with chronic pain are more likely to be socially deprived backgrounds, women, Black and ethnic minorities, refugees, asylum seekers. So we wanted to try and focus on that as well. And the approach that we wanted to do was really to offer a primary care-based personalised care support planning approach, but that we would do this in conjunction with secondary care, so working as part of an MDT and getting support from the secondary care specialist as we need it. We wanted to really try and improve their health and encourage people to be able to self-manage, to understand their pain and really set them off so that they can improve their overall life and well-being in the way that matters to them. So we did this, came up with this pilot model, which we trialled in a large GP practice in North West London. We started in 2001. We've subsequently expanded the similar model. So we've now got 4 PCNs who are currently running something similar and another 2 that are about to start. And the model essentially is that the person is identified by a healthcare professional in primary care. This may be because they have complex chronic pain, they're a frequent attender, they're using services regularly, they've got really complex needs. And this person is invited to have a conversation about their pain with a clinician. At the pilot site, that was with a GP. In some of the newer sites, we're trying it with pharmacists, health coaches and other allied health professionals. And this initial appointment is longer. It's about half an hour. And it's essentially to say to the patient, what do you want to talk about? Rather than us leaving the agenda, it's really true personalised care, saying, tell us about your pain, tell us about your journey, tell us about whatever you want to tell us about. And actually through doing this, we're able to help talk to people about what they understand their pain is caused by, what they understand their diagnosis is, what do they think their needs are rather than what do we think they are, and help them with some early goal setting. From this, sometimes the GP or whoever's delivering that initial appointment will be able to already signpost patients to appropriate resources and services, which might be in the community. We discuss complex patients in an MDT, which I'll come on to talk about in a second. And there may be other services and referrals that already become apparent that the patient might benefit from, such as a pharmacist or a physio or a health coach. The patients have a follow-up appointment with that same clinician a couple of months later, which is around reviewing their goals, their progress, and what was the outcome from that MDT. And alongside this, patients continue to access services in healthcare as they normally would. So this is not designed to be a pain clinic that treats everything. This is just an opportunity for patients to have a really personalised care, holistic approach to their care, just to have a look at their chronic pain as one of their major problems they're dealing with. On to the next slide, please, Molly. So the MDT, these run every 4 to 6 weeks for an hour on Teams. And they're essentially to offer a space for the clinicians involved in this patient's care to explore the diagnosis. So if there's a bit of diagnostic uncertainty, for the GP to ask, discuss the different support options, share resources, and discuss potential referrals. So from the primary care team, we had the GP, we had social prescribers, health coaches, and a primary care pharmacist. And from secondary care, we had a consultant rheumatologist who specialised in pain, a physiotherapist, and a specialist health psychologist with an interest in long-term conditions. And part of this, as I said, was discussing these complex cases. Is this patient suitable for a health coach referral? Do we think they've got fibromyalgia, or is there something more complex going on? Do they need referral into the hospital, or could we avoid that referral? And it also gave the opportunity to think about doing joint consultation. So we had a few patients where, following the MDT, the patient would have an appointment with me as the GP, and on Teams, I'd have the consultant rheumatologist. So we could have a really nice joint consultation all together. And the MDTs allow for ad hoc support to be built, and building relationships between the team members as well. What's the next slide, please? So we did some evaluation of the pilot project in terms of benefits to the patients. We measured their MSK-HQ score, which is a measure of musculoskeletal, non-musculoskeletal symptoms and well-being, and did find a substantial improvement in this. We found improved patient activation measure scores, which is well validated, showing evidence of improvements of understanding and confidence in managing their symptoms. The management was more consistent with NICE guidance, so in terms of chronic pain guidance, for providing a personalised care approach, a patient-centred holistic approach, and prescribing, trying to get that back into consistent with the guidance. And patients really reported having a major benefit from having these ARS roles, so the social prescribers, the health coaches, and these other roles that they didn't necessarily normally get to see to help support them with their pain. And there's just a few comments there from patients from the survey that we did with people who've been through the pathway, about really appreciating feeling validated, having time to actually go through their discussions, and having this kind of follow up where they could kind of build on from what had been going on. In terms of the clinicians and the team, the clinicians actually delivering the appointment found there was also about skilling, improved job satisfaction and variety, which I think in the current climate is extremely important. And actually in the GP team, there was reported to be greater awareness of diagnosis of chronic pain, which is something that we know from a survey we did before the pilot, that actually GPs often lack that confidence in managing it. Crucially, and I think particularly relevant for this, thinking about primary and secondary care, there was this really great improvement in team relationships and MDT working. And this didn't just extend to the chronic pain patients, but people beyond that. So actually it meant that the secondary care clinicians suddenly understood what health coaches could do in primary care. And as GPs, I understood actually what a specialist psychologist could do. So we all understood each other's roles better, and were able to really make sure that we utilise the skills of different members of the teams. And actually, I think from that, we all learned a lot clinically and non-clinically. And it led to things like reduced referrals, reduced inappropriate investigations, and more appropriate prescribing. Finally, in terms of thinking about the system, it's not all about finances, but it's important. The improvement that we saw in the patient activation measure score, that's a really well validated measure and has been shown to improve cost savings and outcomes. The improvement that we saw in the pilot, if that was extrapolated to across the board, we would estimate that we'd save about 3 GP appointments per patient per year, and have quite a substantial demand savings per patient per year for primary and secondary care. Anecdotally, we noticed reduced use of GP appointments, A&E attendances and unplanned admissions, and we saved referrals, partly because we were able to use that MDT, partly because we could do joint consults, partly through upskilling of the team, actually, that we just understood that we didn't need to refer these patients in secondary care and they could be held in the community. There was increased use of the MDTs and the ARS roles, and as I mentioned before, improved prescribing, which was more in line with NICE guidelines, and particularly looking at opioid use as well. With the next slide. I think Carl was going to if you're there, Karen was going to just talk about one of our stories, just very briefly, about one of the patients who we had go through the pathway.
Thank you. So in terms of the pilot, as Selena's just outlined, so this was very much an approach that the health and wellbeing coach focused on, and it worked with an individual that had quite a lot of consistent pain over a number of years and also underlying mental health issues, and they were quite isolated. So they were able to use this particular approach in order to make quite substantial changes for this individual. So they went from actually never leaving their house to actually ending up kayaking and using social interactions with different people. So I think what it shows is the fact that those small consistent changes and behavioural changes and using a number of techniques can actually have a really positive impact for that individual patient that's having long-term pain issues. And as the outcomes clearly show, that reduce the number of hospital appointments, but also GP appointments as well, and shifted their sort of like care from unplanned to planned, and improved their overall health and well-being, as well as improving sort of like monetary and economic efficiencies as well. I'm really conscious of time, so the next few slides just about that highlight how we embed and how do we make that structural and cultural behavioural change within staff and within the system as well. So in order to embed some of that training and learning that we've been happening, we've set up a reflective practice that happens. Myself and Selena host that, and some of the key themes that are coming up around that is around welfare benefit advice, access to physical activities, around techniques for pain management, but it enables people to have that safe, secure sort of like environment where they can learn about key themes that are happening. And also we offer health coaching for pain as well, quite a specific technique. And in terms of our next slide, so we've actually also set up a community of practice as well, which is looking at how do we actually change and bring people together to change the way we work with people that are affected and impacted by pain within the system. And that's largely for patients, our local residents, but also for our health professionals as well. And we're more than happy to share our lovely newsletter that we produced after our second session for our community of practice and share some of that key learning. We have 2 further community of practices to happen in January and March, and then we'll make a decision as a collective around what does that actually mean and what can we do in the future. So thank you for listening, and we've got some key sort of like information in terms of our purposes and aims, and I'm sure the panel will host a number of questions. Thank you.
Great, thanks Kawan, thanks Selena. It was really, really great to hear about how different roles are working so well together in the MDT, and also the extensive impacts for not only the patients but also the clinical team and the wider system as well. So thank you so much for that.